welcome. I'll be talking about balance related to gait and Parkinson's disease. As a movement disorder specialist, this is one of the most important aspects of Parkinson's and activities of daily living and safety as we age with Parkinson's. And as a movement disorder specialist, we try to determine how do we reduce the risk of any sort of issues with Parkinson's related balance. So I'll give you clues into what we look for as neurologists, let alone just movement disorders. Objectives today will be, again, understanding the impact of walking as a disability and what to look for. We're going to talk about appropriate medical evaluation from a neurologist perspective, and also kind of discussing the importance of physical therapy, getting workup appropriately with your primary care doctor and cardiologist. We'll understand the complexities of walking, and there's a lot of research that's gone on about how balance and gait is related to the cognition in Parkinson's disease. And we'll talk about therapies, and typically most of the therapies and discussions will be done through our question and answer towards the end. So please feel free to bring in questions as directed already. So most patients, when they come into our clinics, there's vague comments of unsteadiness, slowness, dizziness, and these are all utilized sometimes related to gait and balance. We want to understand why patients fall or feel unsteady, but the moment we start hearing about dizziness and lightheadedness, we presume there may be a combination of how the eyes and ears coordinate with our brain, how our eyes, ears, and then central nervous system affects our immediate balance of our legs and reaction times. So these are the type of things that we look for. And the dizziness that most patients with Parkinson's state when they come into our clinics is usually like a feeling of unsteady, like they're rocking on a boat. And that gives us an idea that there's an off-centered issue of their center of gravity and their balance upon standing. So these are situations that when we're looking for our answers, we want to be more specific. The questions have to be, when are we having balance issues? What is the determining factors? And that's when we ask, is it happening when you're getting in and out of a chair? Is it when you're taking quick turns? Is it through a doorway? We want to ask certain aspects of speed of walking. Are you going slow when you're having imbalance, or is it when you're walking fast? Do you notice that you're better going up steps or down steps? These are, again, situations that we do see that sometimes patients are better in different gradations. Certain surfaces are better for patients and maybe worse on others. We want to understand by family members about the length of steps that patients take, the width separated by the feet. And there's initiation factors where patients first try to get out of the chair and they may take short steps. We call it festination. And then patients may speed up where they can't control their legs. So the details of the environment are so key. Do people feel imbalanced or that dizziness when they are lying down as well? Or is it just when they stand on their 2 feet? Does it occur when they're sitting in a chair? And does that become more unsteadiness or balance in a stationary position when trying to turn? So we want to understand, is that dizziness or unbalance also when we sit? Because there may be other factors like tremors that can make us feel shaky and imbalanced even when we're sitting. Sometimes we have patients with no hand tremors but only leg tremors, and when they're standing in one spot, their balance could be off because of the tremors that are signaled in their off state or when their meds are not working. Like I commented earlier, we've seen patients feel only imbalanced maybe when they're going up or down steps. The visual cues of the steps can also be misleading for people with Parkinson's. And we see with advancing disease of Parkinson's that this visual spatial depth perception is off, and it can make people feel like they're almost in a dizzy state or in a vertiginous state. So we always want to ask, when people complain of imbalance, are you feeling lightheaded? Have you fainted? Is there weakness of certain muscles, or are you also experiencing any numbness or tingling? Unfortunately, when someone gets Parkinson's, they may also have other conditions like hypertension, diabetes, may have had a stroke or not. And such things like diabetes may also cause already some numbness, which adds to this delayed perception of the feet on the ground and different steps. And that again affects balance significantly. So we want to always understand one's medical history. Some surgeries may affect people as well. If they've had lumbar surgeries, back pain that's caused by a disc bulge, they may be chronic history of nerve damage at the back that again affects the sensory and motor symptoms or motor fibers of the legs. So again, the clinical history is so valuable for us. And for a movement disorder specialist, we really want to understand medications, especially those that lower blood pressure. With Parkinson's disease, we see a lot of abnormal, erratic blood pressures. Sometimes it's low, sometimes it's high. It can happen when someone's just sitting down and there's a lot of lability with the blood pressures. And then that happens as well with standing for patients. But we've seen in patients with taking certain Parkinson's medicines that also upon standing, the blood pressure drops significantly, which creates this gait imbalance factor. So gait disturbances, walking instability affects, we know, all aspects of life. And our concern is, can we avoid the serious injuries? Can we prevent the long-term disabilities that can lead to loss of independence? We want quality of life to be as strong as possible, as good as can be, and we want to avoid the institutional circumstances that come with consequences of falls. We also know that there's a significant burden with cost to the healthcare system based on needing helpers, nighttime caregivers, extra physical therapy, occupational therapy, and unfortunately, with these falls, that can lead to bleeds in the brain or fractures, and then secondary surgeries. There's higher rates of mortality. What we've seen in a large population-based study, that there's prevalence of balance issues, gait abnormalities. In patients 70 years and older, it was about 35%. And as we get older with age, 46% of patients can reported balance issues 85 and older. Now, this is again a circumstance where 50% of people 85 and older are at risk of falling because they feel unsteady. And we need to understand that with walking, especially with Parkinson's, we always think of walking as a motor task, but I want to teach upon you today that it's not just a basic reflex. It's not that we knew how to walk when we were born. We learned how to walk, and we learned how to walk slowly, and we had this development of our central nervous system, around 6 months to 9 months of age. And when we are dealing with Parkinson's, we end up having a deterioration or breakdown of these same pathways that we've learned when we were children or babies. And this aspects of these fine cortical processing centers, sensory centers, motor centers, we lose that with Parkinson's as it's progressing. So I want you to understand it's a very complex system that we have, and the aspects of walking kind of starts like a locomotion. We start off slow with Parkinson's. We may have to build up speed and then we can walk better. But what we do know with age, without Parkinson's and with Parkinson's, there is a reduction of gait velocity. Our stride length is also reduced by 20%. The characteristics of aging, as we see, is commonly aging changes our stance. So we have an increased width in how we stand. There's increased time spent in what's called double support phase, where both feet are on the ground. So when we're taking steps and trying to push off, maybe we have a reduction in the swing phase of our legs from right leg to left leg. We have also a bent posture. We've also know that there's less vigorous force with each push off, which again leads to less height of our step, and we can catch ourselves on, an uneven surface, a curb, So it's, again, very important to understand these characteristics. With Parkinson's, a lot of the physical therapies have been based on talking about big and loud. And one of the aspects of big is big steps, large exaggerated movements. And this is something we have to combat with the characteristics of aging and walking. So with patients who have Parkinson's and a flexed posture, their center of gravity is much more forward. And we have to be able to adjust for that when we're changing positions from sitting to standing or laying down flat to sitting up and then trying to get up from a chair or bed. The center of gravity is much more forward, and that's where we can have an instability of our legs not being able to catch up to our flexed posture. I wanted to show you some studies that have gone on for many years, and even the last 20 years there's been a better understanding of walking and balance. But one of the aspects that is important is dual task performances in patients with Parkinson's and not with Parkinson's. So in healthy subjects, which means those without Parkinson's, for instance, if you're trying to carry something, or you're carrying grocery bags in both hands and walking, maybe talking on the phone, being distracted and walking, those are dual tasks. Walking is one task, and then whatever you're doing with your hands or talking with someone is the second task. Studies have been shown that even in healthy people, that motor errors were related to the complexity of the dual task. So for instance, if someone was walking and counting backwards, we see a variability in one's walking. There's a reduction in one's speed and steppage. If someone's, for instance, being distracted with talking with someone on the phone, maybe it's dark, so we have to look at visual cues and maybe our hands are out more. Those are concerns that we have with dual tasking. So we know with healthy subjects that when they're trying to recite alphabet backwards or spell words in reverse, there is continuous evidence that the walking speed and balance and sway is variable and worse. So this is, again, with healthy subjects with dual task. When we look at patients who have dual task with memory issues, for instance, Alzheimer's or mild cognitive impairment, we see that the more severe cognitive impairment, the worse it affects balance. So here are a few studies that showed that when patients with a decline in their thinking were doing dual tasks, again, either spelling, reading something, subtracting numbers from 100, there was, again, much more variability, further reduction in speed of walking. And again, this is much more determined that the worse the memory, the worse the balance issues and higher risk of falls. And this is based on different assessments of balance and gait. So with dual task processing in Parkinson's, what we know is that patients display already a greater amount of gait asymmetry. One side's always more affected in Parkinson's based on tremor, stiffness, and slowness. That stiffness and slowness, again, asymmetric on one side more than the other. So one leg could be not stepping as properly, forcefully, quickly. And we know that there's a reduction in bilateral coordination based on the studies. We know that there's increased variability when patients with Parkinson's do dual tasks. So the more we're distracted, the more variability we see with that leg that's slower, stiffer, and less reactive. And this was compared with age-matched controls during the same dual task conditions. So typically with Parkinson's disease, we already have a reduced speed, and that affects our reaction times. So with the dual task and cognitive processing or the demands of what we're thinking about really affect patients. I see many times when my patients are walking down the hall, when I'm examining their gait and they get distracted and look into a different doorway, they start shuffling their feet. Again, goes to the aspect of just being distracted as a dual task. And we've seen this in numerous clinical studies, whether they're retrospective studies. And we go into, there's been a discussion about what's called wrong prioritization, which means you need to, when you're walking, you need to focus on walking, when you need to start talking, you stop walking, and then you have that discussion. So we want to have the priority of walking only. If you're using a cane or walker, you utilize that carefully, what is most ideal based on the physical therapy assessments, but maybe not to also use something that's too complex. So it maybe certain walkers aren't as good for us, and trying to prioritize our steppage may be distracted by the holding on to the walker that's maybe not appropriate. Some walkers may be better than others. Maybe some canes may be better than others, or some walking sticks may be more appropriate. So we've seen that even if you are utilizing some aid, it has to be, you have to still prioritize and make sure that you're coordinating your legs in an appropriate fashion. Some people talk out loud and state right, left, or 1, 2. Some of our physical therapists teach our patients to say heel, toe, and that helps with, again, prioritizing each step. But we do see that patients with Parkinson's who have intact cognition, they are better in their ability to take better steps, similar to healthy adults without Parkinson's. However, as we age with Parkinson's and we see cognitive decline, it's far more difficult to take proper steps, and we see more freezing of gait. There's been studies that show that if there's a decline in verbal fluency, there's higher rates of this disability, and sometimes we see this verbal fluency tested on neuropsych testing. What further makes it complicated is if we have white matter disease, which is what you see on the left of the brain scans. When you see mild to moderate and severe amount of white matter disease, the white color, the bright areas, that also adds to instability of walking. These certain areas and pathways affect steppage, and we believe that there's a subtype called postural instability gait difficulty in Parkinson's, whereas others may be tremor predominant. There's a specific also affected areas of the brain that makes someone have characteristics of this PIGD subtype. When we look at the white matter decline based on injury, there's also sometimes a cognitive impairment as well. There's also atrophy in certain areas of the brain, which means a reduction of the size. And there's been data that show that those who have more freezing of gait or difficulty with dual task performances, there may be a reduction in certain areas of the brain. And as we see with that arrow pointing on the far right, the corpus callosum, there's some atrophy or reduction in size versus someone who's healthy and more of a thick, robust size. There are, again, more disturbances of gait and balance. So reaction times are sometimes slowed, and those signals that occur from the brain down the spinal cord to the legs and back up, again, those signals are delayed, which again worsens one's gait. So medical conditions that again affect balance in Parkinson's, we don't want to underestimate hyper or hypothyroidism. There's heart conditions that, again, if we have an irregular heartbeat, if we have slow heartbeats that require maybe a pacemaker, we know other neurological conditions may affect patients' balance, including B12 deficiencies. If you already have had a stroke or have musculoskeletal weakness, that also affects our patients. With walking, if you have gout, make sure that's treated. If you have spinal stenosis, that can worsen one's balance with Parkinson's. And as we see bone issues, including osteoarthritis, that can be affecting our low back pain at the knees, again, will affect our balance. We know that someone who just maybe had new medicines for an infection and they're maybe confused, that will increase the risk of imbalance, so delirium. If you're having low sodium levels, low glucose, this again adds to coordination issues. If there's been spinal cord injury, that can also affect how our balance is and our reaction time. Muscles may be more rigid and stiff, affecting our Parkinson's as well. And I don't want to underestimate vision impairment. Please check with the optometrist or ophthalmologist at least once a year to monitor for such situations of nighttime imbalance. Now, the neurological exam is very important, where when a patient comes in, we want to assess their thinking, their processing. We need to understand as well if they've had issues with their vestibular, their hearing and eye pathways. Sometimes we do see that maybe someone has vertigo, they have something called nystagmus, maybe medications are affecting their ear, eyes, coordination, and there's certain areas of the brain that can be affected by certain meds, maybe certain blood pressure medications as well. We want to be able to check that there's good blood flow from the carotid arteries that are, again, we need to have good blood flow to the brain in all aspects. And if we see low blood flow, then higher risk of falls as well. If there are heart conditions, that allows us to be very particular in making sure we do the right referrals. It's kind of like if we have back issues, we want to see the orthopedist appropriately. And these are different tests that we do as neurologists. We look for vision, we look for strength and power, make sure there's no fatigability. A lot of imbalance with Parkinson's gets worse as the day goes on. There's, again, a lot of fatigability in the legs of patients with Parkinson's. We see that posture gets worse as the day goes on. And we need to look for sensory abnormalities that may affect gait as well. There's certain tests that we do with finger to nose testing to make sure certain aspects of the brain, like the cerebellum, are intact. And we do see that that may be a sign of maybe a vitamin E deficiency. So our examination involves quite comprehensive head to toe visualization. We want to see how people are standing, whether they're with their eyes open or closed. We test their cadence, their speed walking down the hallway, sometimes even by distracting them and telling them the days of the week backwards. We want to understand steppage, how they turn, how they stop, how their arm swings. And again, we've also seen where balance is really much affected with how your hands are. So we see a lot more imbalance with hands in the pocket. Keep your hands out, swing them freely and appropriately side to side. And that allows also to improve balance where you have better sway. We do certain tests, again, to look at the stance, swing phases, and making sure that our patients are putting pressure on their feet and pushing off accordingly. And again, we want to understand posture. Again, if we're much more flexed, we're going to have what's called fascination and short steps, short, fast steps that lead us to falling. When a patient's coming into our clinic, again, we're going to look for certain blood tests. If we see some sensory abnormalities like B12, we want to get neuroimaging. And again, hopefully today you're comfortable understanding that you have to be proactive about balance and reducing risk of falls. And sometimes, you know, some doctors may be late on doing imaging of the brain. Again, ask the neurologist to maybe get an updated imaging in case there's a concern of imbalance from a fall, making sure there's no bleed or stroke. And we sometimes do certain testing on the cerebrospinal fluid, we call it CSF, in case there is a buildup of spinal fluid in the brain and the ventricles. So it's very important to be following with your cardiologist in case your heart's not pumping well. And we do certain tests, again, to make sure that we're stable. As we look for classifications of walking, please be mindful of when are these imbalances occurring? Is it happening all the time? Is this something that is episodic, that's unpredictable? And then it cues us as neurologists and movement specialists to determine what the cause could be. So with cognition and gait, hopefully we've understood that when there is a decline in our thinking, maybe forgetful with words, maybe forgetful with fluency of how we get words out from our mouth, we do see a correlation with freezing of gait. Some patients may have a visual spatial decline in cognition, and that again may affect how they will go through doorways, different surfaces, tight spaces, maybe closets. And so executive attention is also very important in walking. This is just a brief diagram kind of understanding how the brain and different pathways are involved. We're showing here dopamine pathways in the basal ganglia, which is what we know is reduced in Parkinson's. These pathways are affected by our emotional response. If we see a fire, we're going to get, our heart's going to beat fast. We're trying to get out away from the fire. It sends signals to the midbrain and it goes down to the spinal cord and sends signals to move our legs fast. Sometimes before our basal ganglia can even react voluntarily. We, again, use volitional processing to tell ourselves, pick up our feet, swing your arms big. And again, there's interactions with our basal ganglia. Sensory signals, of course, from our environment may affect us significantly, especially where we see a ball being thrown at us. Maybe a person with Parkinson's who looks slow may be able to catch a ball very quickly if it's coming their direction. Our reflexes may be quite good with Parkinson's, even if we look slow. Maybe if a book is falling, we can quickly react. And then again, the cerebellum has different pathways that we see with the basal ganglia and how we get sensory feedback and make smooth, coordinated movements, whether it's with our hands or feet. And that's, again, affects balance significantly, as we see as all these pathways work our way down to the spinal cord to the legs. So this is a way of looking at cognition and volitional response, where you think of something as you're processing the illicit movement. We send signals from the higher level cortical regions down to the spinal cord to the muscles, and then we're able to run quickly. And we, again, as we think about it and we do it, like, again, picking up our feet, right, left, we can do this as a cognitive volitional process. So a lot of different processes go on. We know if we have strokes to certain areas of our brain, that will affect our balance as well. The frontal areas of our brain affect initiation of gaits. We know that if we affect primary motor centers or secondary motor centers, that will, or certain planning centers of our brain, pre-planning centers, that also affects freezing of gait and getting started. So there's motor strip and sensory strip, but certain areas before we send a signal to the areas of the brain that make movement, the pre-planning areas could be reduced in size. And if there's reduction in the size of these areas, whether it's from injury, trauma, degeneration from Parkinson's or Alzheimer's, we do see that that pre-planning areas affect how we take steps appropriately. So in emotional response, we call it flight or fight reactions. These are projections of areas in the brain called the limbic center and the hypothalamus that send signals and may bypass actually our basal ganglia. And sometimes with music, listening to things that are upbeat, we may be able to get better steps, better rhythm, improve our cadence, which again may help us. So if we think about something that is scary, we may have an emotional response, react a certain way, and that hyper aspect will make us fight or flight and run. So emotional responses can be uplifting, they can be shocking, but they kind of jar the system. So first and foremost, prevention, get a home health safety, be very cautious with what's around, grab bars in the bathroom, be mindful of keeping spaces open. If there's coffee tables all around that need to be maybe moved aside so you can have more of an open space, we can reduce the risk of shuffling of gait. Wear appropriate footwear, avoid sandals if you already are shuffling your feet. We want to, again, see the physical therapy upon onset of imbalance. If you feel like you're weak, fatiguing, need evaluation with assistive device, physical therapy is highly important. If there's cognitive decline, there have been studies that have shown starting certain medicines to boost alertness and cognition may help freezing of gait. And again, it's very individualized with what medicines may work or help. There are, again, Parkinson's medicines that we have to adjust, make sure that maybe we're more continuous in our dosing, make sure we're not missing medicines, and keeping very regular. The compliance of taking carbidopa, levodopa, or certain dopamine therapies is so important that when the medicine is wearing off, maybe we're more at risk of falling. So we want to be mindful that how the timing of our meds affects our day-to-day rotation, turning, twisting, and that's key. And again, if there is any vitamin deficiencies, nerve issues, have that corrected properly. With walking, you can do this at home, but work on your hip flexors, lifting up one leg at a time. You can do this sitting down, maybe having an extra weight. Physical therapists do a good job of working on strengthening those hip flexors. If there's anything you can do is work on your abs and hip flexors. Also, the extension of the knee is important. And, you know, the knee flexion can also be very important because it helps with pushing off. So if we can strengthen around the knee and really focus individual muscles, that really helps with balance and instability. And as we know with Parkinson's, most of the imbalance occurs one side more than the other. As we walk longer, our toes and our push-offs get weaker. So really focusing on foot flexion is another aspect of therapy. Individualizing here, as we see with bands, the plantar flexion of the foot, again, working individually one at a time, and the dorsiflexion of the toes, again, very important. So there's extension and dorsiflexion, which is important. So again, from a conclusion of understanding, see your neurologist for balance issues. Hopefully a movement disorder specialist can be of utility. If it's Parkinson's related, make sure you see regularly your cardiologist, ear, nose, and throat in case there's some ear tinnitus, hearing issues, or loss of hearing that may affect balance. Check your eyes with your appropriate ophthalmologist. And as we know, walking can affect all aspects of life. Be very candid with your neurologist about how your balance is so we can act upon it sooner than later. We need to do a thorough evaluation, follow up appropriately with physical therapy and occupational therapy. And if there's any memory issues, the caregivers need to be definitely much more aware of this, that how it can affect balance.